Hello, everyone, and welcome to today's webinar. It's all about revenue, MIPS, and cardiology best practices. My name is Alex Goulding. I'm the Public Policy Manager here at iHealth and will serve as your moderator for today's presentation. Before we get started, I'd like to go over a few items so you know how to participate in today's event. Everyone on this call is listening in using your computer speaker system by default. If you prefer to join over the phone, just select telephone in the audio pane on the right-hand side of your screen, and the dial-in information will be displayed. You'll have the opportunity to submit questions during today's presentation by typing your questions into the questions pane of the control panel. You may send in your questions at any time during the presentation. We will collect these and, time permitting, address them during the Q&A session at the end of today's presentation. Also, please note that today's slides will be shared in a follow-up email after this presentation in case you want to review again or share with any peers. Before I introduce today's speaker, I would like to note that today's webinar is the 5th webinar of iHealth Innovation's MACRA Final Rule series. Please keep an eye out for our upcoming Final Rule webinars, including a MACRA Final Rule overview and additional specialty-focused webinars for orthopedics, primary care, and radiology. I would now like to introduce Justin Barnes. Justin is a corporate, board, and public policy advisor. In addition, he's chairman emeritus of the HIMSS EHR Association, co-chairman of the Accountable Care Community of Practice, and partner at iHealth, where he assists organizations with industry strategy and leadership. Justin is also the host of the weekly syndicated radio show This Just In on Healthcare Radio and Business Radio X. Justin has formally addressed or testified before Congress, as well as the last 2 presidential administrations, on more than 20 occasions. He's appeared in more than 1,200 journals, magazines, and broadcast outlets. With that, let me turn today's presentation over to you, Justin.
Thank you very much, Alex, and thank you very much to everybody for joining us this afternoon. We're going to spend about 30 minutes, but if you've ever heard me speak before, I do tend to speak fast. I'll try to slow down. But also, we cover a lot of content. As Alex mentioned, this is our 5th webinar in our MACRA series and our MIPS series, and all of this content will be available to you after. We'll share it usually within 24 to 48 hours. But we do try to pack in a lot. So we'll be able to slow down at times and cover some items in detail. But again, we'll share all this content with you. You can review it at your availability later on as well, and then also re-record or listen to the recording again. And also on December 1st, we'll actually have another webinar that covers MACRA at a much greater level. This one's specifically focused on cardiology, but again, we'll do one December 1st. It's on our website, iHealthInnovations.com, and in the webinars and events section. And you can see December 1st at, I think it's 12 p.m. Eastern, we will have another webinar about an hour long covering MACRA with best practices at a much higher level, not drilling in specifically to cardiology. So let's take a quick step back before we dive into MIPS and cardiology and the quality payment program specifically. I want to touch a little bit at a high level because kind of when you look out over the next couple of years where there's opportunities to generate more revenue and increase cash flow for your practice, I want to really touch on that and impress on a couple of points here because there's more opportunity here just by optimizing your revenue cycle and finding those financial components and really optimizing them it's about a 9-to-1 ratio from the standpoint of how much money you can make on the revenue cycle side regarding what you can make, at least over the next couple of years, 2-3 years, from quality reporting. Quality reporting is critically important, and we're going to walk through some of those calculations and all that specifically for cardiology. But when you really look at the financial aspects of optimizing your opportunity long term, and certainly even in the next couple of years, it's really focused on the revenue cycle. It's focused on new services and care delivery opportunities for your specialty and certainly for cardiology, as well as specialty-specific quality reporting programs. And a lot of states have them. Medicare is not the only one at the national level. There are a lot of the plans offer specific cardiology-type quality reporting programs. And so there's certainly some money there. And so if you look at optimizing your revenue cycle, new services or innovations you might be able to utilize, or even different types of equipment, but then also participating in quality reporting initiatives, you really have a holistic opportunity and a very large opportunity to increase, average practice maybe for a cardiologist, $200,000 to $300,000, $400,000. or more, depending upon how large your operation is. If you're up towards 6, 7 providers, you might be 350, 400,000, 500,000 or more of additional revenue. So just a real great opportunity. And that's why I want to kind of cover that here in the short run before we dive into the MIPS and the quality reporting initiatives. So when you talk about optimizing, I'm talking about aligning processes, service lines, and innovation. I'm going to dive into some of the processes and services here in a moment. Before I do, I'll touch on scheduling. Usually in a medical practice, it's one of the higher areas for issue for reducing patient satisfaction. It's difficult to schedule appointments or reach somebody to make an appointment, or the back and forth, and you want to pay attention to that. It's revenue, it's getting the patient in there, it's capturing business, but also patient satisfaction is going to be 5 to 15% of your revenue stream moving forward, even under MIPS, but then other quality payment programs and value-based medicine type programs that are going to be coming. So you want to focus on patient satisfaction. Scheduling is a piece of it. Appointments. Not only make it easy to schedule an appointment, but also be seen. Not have to wait more than a half an hour. There's a direct correlation between someone sitting in a waiting room for more than 30 minutes and their level of satisfaction. And also, then that extends to the quality of care they receive. It doesn't matter what the doctor or PA or MA did. It actually, if they sit there for more than 45 minutes, they just feel that the quality of care is decreased and the satisfaction is decreased. So that wait time is very important to manage. A lot of great innovations out there around that. Clockwise MD is one that I like. And also the scheduling aspect, I think Clockwise does that. Great product. And then also on the payment side, make it easy to do business with your organization. That's certainly around the scheduling and appointment side, but also make it easy to understand a bill and pay a bill, and maybe offer a payment plan. Again, lots of innovations out there that could be interesting. There's one out there called Patient Code that I like on the patient payment side, but there's lots of different ones out there. These innovations have tremendous ROI, pennies in the dollar to implement, and can really modernize your practice in some of the real key areas to bring more to the bottom line. Now diving in specifically to your revenue cycle. Opportunities to really optimize your documentation and mitigate issues as well as reduce risk. How do you do that? You really audit provider workflow. Make sure that we're capturing the right information at the right time and using the right code. And also, certainly with ICD-10, lots of opportunities to not use the right code at the right time or not receive the right payment and reimbursement. So I think there's something, or even just get a denial. So I think there's something that, when we go into a practice, we can actually get an extra 30 or 40% ROI. When we say if we're going to bring an extra $200,000 to $300,000, 30% of that is found just on the coding side. So we see under documentation, people not getting paid for what they did, certainly the hard work that they're doing. So assessments, questionnaires, evaluation, service, tests, and screening, that all, if you can implement that and make sure that the documentation is done at the right time during that visit, you're using the right code at the right time, you make more money, but also that all counts towards your MIPS scoring. So again, let your EHR, let your health IT platform work for you without you having to do all the extra work. We also recommend doing random chart audits, usually 5 to 10 per provider, do them monthly or bi-monthly. Not by the same people who do the billing every single day, because they don't know what they don't know, unfortunately. But you get an expert biller, there's co-sourcing, there's experts out there, some of the things that we do. We go in there, and when we do these audits, we look for missing charges, looking for consultations, no notes, wrong provider noted, down coding, up coding, wrong ICD-10 codes, missing modifiers. Those are all revenue leakage components, but if you do them right, they'll prevent rejections, denials, and audits. So again, 30% of the ROI that we tend to find, we usually say that we can find 5 to 15% additional revenue and cash flow for a practice. That's the 30% of that is made up of just coding and doing the coding accurately and comprehensive coding. As I mentioned quickly before, keep the future in mind. You can optimize coding inside your EHR. Make sure you're using the right code at the right time, place it at the right time in the visit, and make sure it's modified, those codes or whatever you want to do within your EHR is customized for PQRS, for MIPS, for alternative payment models, and quality reporting initiatives. If you do all this on the front end, it'll make the back end a lot easier. It'll make all your quality reporting better. You'll score much better in whatever program you're going to participate in, certainly PQRS, MIPS, even meaningful use, by doing the front end work. And this is some of the best practices that we love to offer practices and hospitals for that matter. But it's usually, again, one of the areas we can find some good ROI. And also, this is an area to reduce clicks. People always talk about too many clicks inside an EHR or their health IT platform that they're using. This is a great area. Managing credentialing, monitoring PAR, non-PAR providers. The bottom line there is you got to play the game with the payers. And that's something that we do very, very well, and certainly hopefully your team does as well. But keep an eye on. We have one of our customers up in New York, a large health system. Their payer takes their physicians off the rolls every single month. So we have to re-credential our doctors and our providers every single month. So that's probably an extra $9 million by playing that game annually to our hospital, playing the game with the payers. So in a practice, it could be anywhere from $50,000 to $200,000 right there, depending on the size of the practice and the payer and what's going on. But you got to make sure that you're playing the game with the payers. Optimize collections through eligibility verification and prior authorization. Certainly, as a specialist, it's critically important to make sure you're getting paid for the visit. And also managing fee schedules. Something around, we say the best practice here is every 6 to 12 months. It's something that we like to deploy. The reason being is payers usually don't overpay you. Traditionally, they underpay you, and understanding that variance is critically important. A lot of money at stake there. And also a service that we like to perform, it's not on the slide right now, is if you're looking at bringing in new equipment or something like that, companies like us or partners like us could actually run the numbers against your current fee schedules to see if that's actually there's good ROI there. The sales guy walking in is going to tell you, oh, all this great ROI. Well, if they haven't looked at your fee schedule, they have no clue. They really don't know. So it's something that we look to offer our practices. Again, lots of great opportunity for more money there. I'm not going to walk through all of these denial opportunities, but really we deploy anywhere from, depending on the specialty, 5 to 15 to 20 different best practices to avoid denials based on per specialty. So for cardiology, here are some general ones that we come across. And again, all of this content will be shared with you and posted online, but we'll be emailing it to everybody in the next 24 to 48 hours so you can see. But again, these are things to look for. We always have between 15 and 20 that we'll sit with the practice when we're working with them and make sure that we do this. So, and real quickly, on the denial side, only 60% of practices actually appeal their denials. That's a lot of money that's being left out there. We appeal 100%. And so our recommendation in best practices, be tenacious, appeal 100% of your denials, and then also go to the root cause of those denials. So you don't keep on having them over and over again because that's wasted work. You can fix them, go to the root cause, run the analytics and analysis to find out the root cause. So something that we deploy and near here to our heart. Now, diving specifically into MACRA and MIPS, we all know the legislation was passed in 2015. We got the final rule back last month. And very important, I'll take one quick note of this because we just had the election and the Republicans took control, obviously, of the presidency as well as they had control of the Congress, but now all three here. But with MACRA is a bipartisan bill. It was a bipartisan bill, and it's bipartisan regulation. So there's no one out there that is talking about overturning it or repealing it or turning it back or anything like that. Certainly with health insurance reform, the ACA and Obamacare, yes, you're going to see components of that get changed. But that has zero effect on any component within MACRA, within MIPS, or even really alternative payment models. Because even some of that was in the ACA were Republican strategies, Republican tenets around accountable care and value-based medicine before they were part of the Democratic platform and Obama's bill that came out back in 2010. So no changes to MACRA on the horizon, and not a single person out there that's a key stakeholder is saying anything about changing it. So you're in good hands there. Also, you're in very good hands because MACRA, MIPS, and the Quality Payment Program, the QPP, these are all very attainable by your practice. If you're taking the time to hear my voice today and listen to this presentation, you're going to be served very well by MIPS. Great opportunity not only to stave off a 4% cut, but to earn up to a 4% increase. So option one, everybody's going to be able to qualify for this fairly simply. Report one quality measure, one improvement activity, or 5 advancing care information measures to avoid a payment adjustment. And you have to do one of those over a 90-day period. So very simply, one quality measure, one improvement activity, 5 ACI measures over a 90-day period, you stave off that 4% pending cut. That is easier than any quality reporting program that you probably ever participated in. It's much easier than PQRS, much easier than Meaningful Use. So just please know that this program, certainly over the last several months, was really customized to be successful for practices. So option one, everybody should be good there, certainly if you partner with somebody like us, or even just listen to what I'm saying and deploy some of the best practices that we share in here. Option two allows providers to submit measures and activity data for 90 days. This means their period could begin later than January 1st. I think everybody knows that MACRA, MIPS, and the QPP all starts on January 1st, so less than 45 days, 43 days from now. So we do want to make sure that we're ready and moving in this direction. And you're here today and you're listening, so you are. If you do this, and this could be a subset of measures or a handful of measures, a handful of activities over a 90-day period, you can get a neutral or even a small payment adjustment. So again, maybe 90 days or 180 days or so forth, and you're well positioned to get a 1 or 2% increase, hopefully. Option three, you're ready to go in January for the full 365-day reporting period. Hopefully, you're using a MIPS certified EHR or at least an EHR that can capture a lot of those MIPS objectives. Like the one that I work closely with now is eClinicalWorks, ECW, but I'm sure there's a bunch out there that can do it. I hope there are. But this starts January 1st, and if you go the full year, you'd be very well on your way for a 3 or 4% increase. So again, this is a very flexible step program. Probably most people are going to go for 90 to 180 days, maybe 270 days, and see how it works for them. But a great opportunity there to get a 1, 2, 3% increase. Option four, I don't think there's anything on the phone, but that's really if you're in an advanced alternative payment model, such as a Medicare Shared Savings ACO Track 2 or Track 3 or the CPC Plus. So I'm going to really focus a lot of my comments on the MIPS program, not the AAPM. But so quickly, I think everybody's seen these numbers by now. Plus or minus 4%. If you choose not to participate at all, you'll get a 4% cut. But if you do choose to participate in the program, hopefully in 2017, we'd love to help you there. You might get a 1, 2, or 3%, or even a 4% increase. Year two, and these are cumulative, you got a 5% increase year two, or decrease if you ignore the program, a 7% increase opportunity, or 7% cut, year three, and 9% in year four, plus or minus, depending upon if you choose to participate in the program or not. And this is all cumulative, so it's a lot of money if you do not choose to engage the program. Now, diving onto the categories, for 2017, there are actually only three. There was one that was pushed out until 2018 that will replace the value-based modifier. So for right now, for the immediate future, you'll be focused on quality, advancing care information, and improvement activities. So quality will replace PQRS, and that accounts for 60% of your total score. And then advancing care information will replace meaningful use, and that's 25% of your total score. And then with a new category called improvement activities, and there are 93 to choose from, you'll need to do 4 or 2, depending upon a high-weighted one or not, a high-weighted or medium-weighted measure. So I'm going to dive all into that here in a moment. But again, very simple. If you're doing PQRS or you've done meaningful use or a combination of both, you're going to be in great shape to get a good 1, 2, or 3% increase, certainly if you have the right partner. So on the quality side, as I mentioned, 60% of your waste, and there are 20 measures to choose from, and you only need to pick 6. All specialties only need to pick 6. But in cardiology, to show the flexibility, there's 20 to look at, but there are only 6 that you need to do for cardiology. So I think it shows the flexibility. And technically, you can pick any of those 200 plus. If there are other that are more applicable to your workflow and your practice of medicine, you can pick up to from a list of 200. And again, you only need to do 6. One outcome measure. So part of your 6 quality measures, you must pick one outcome measure. And we're going to show you all of this in the subsequent slide, what these look like. Now, on the advancing care information, it's 25% of your weighted score. If you're using a MIPS certified EHR, you have to report 5. You'll have 15 to choose from, but you have to report 5. And if you're not using a MIPS certified EHR, then you'll have to report 4 and then pick 1 as well from another list. So you'll actually have to pick 5 in your first year if that's the measure you want to go for. Remember, you only have to do 1 quality measure, 1 improvement activity, or 5 advancing care information measures if you want to just save up to 4%. But if you want to go for 1, 2, or 3, or 4% increase, then you have to do a combination of these. You have to do 6 quality measures, either 5 or 4 advancing care information measures, and then on the improvement activities, you have to do 4 or up to 4. You can actually do 2 high-weighted ones, and that will count as 4. So again, 93 to choose from on the improvement activities. All of this shows a lot of flexibility that people have no matter what their specialty is. So some key takeaways before I dive into some of the calculations and the exact measures. Pick your pace. So again, you can go for 90 days, you can go for 180 days, 270, whatever it is, 200, however days you want to go, you can go. Highly flexible. So these objectives and measures are based to fit your practice, your specialty, and your workflow. And certainly for cardiology, you have 20 quality measures to choose from. You'll have 93 improvement activities and and up to 15 advancing care information measures. So a lot of flexibility to make sure that it's relevant to you and your specialty. Also, it's not all or nothing. You can get partial credit and bonuses available to avoid penalties and also increase your payments. And this is unlike meaningful use. You have to report all of the measures or you didn't get your meaningful use money. The MIPS and the quality payment program are not like that. So it's not all or nothing. It's very flexible. I published about 2 weeks ago a 4-point plan for MACRA in MIPS success. When we share the slide deck out with you, you can just click on this link on the slide, or you can just Google MACRA final rule and Becker's Hospital Review, and you'll find it. But I cover 4 tenets, and I've covered some of this on the call today, but I go into much more granularity and best practice planning. But you want to look at financial success. I already talked about optimizing your revenue cycle. 90% of your additional revenue opportunity over the next couple of years is going to come from optimizing your revenue cycle, not quality reporting. But that will also level up. I mean, in years 2019, 2020, 2021, you'll start to get more money coming from quality reporting, but always keeping your revenue cycle optimized is where 50, 60, 70 or more % of revenue and optimization is going to come from, and cash flow. Clinical success, I mentioned this before, focus on documentation, making sure your EHR is tuned up and optimized to how your care providers are practicing medicine. And make sure you're reducing clicks, and you can all do that. And make sure you're handling population health and care coordination, and that's going to be very key, all integrated into to MIPS and the quality payment program, and certainly into a lot of our EHRs today, which is terrific. Technical success, optimize your infrastructure. I already mentioned customizing your EHR. Make sure you have your dashboard set up, your KPI set up. KPI is key performance indicator. You want them installed for your finances and your revenue cycle, and you also want them installed and implemented on your quality side. You want to see how you're doing on your MIPS scoring, and certainly you hopefully have a meaningful use dashboard. You want to make sure that certainly we have the same thing for MIPS, and we'll have to set that all up for you. In staff success, making sure your staff is optimized. They understand, they're bought into where healthcare is going and how your practice is evolving. They understand MACRA, they understand what they need to do, and a lot of opportunity here to also align staff. As you begin to align your revenue cycle, you can also push people to revenue-generating opportunities around quality reporting and in other financial aspects. And I cover a lot of that inside that best practice document. So now diving into some of the adjustment incentives overview. So for cardiology, for an average 5-doctor practice, you've got a $44,000 first-year opportunity. In your second year, you get an extra $55,000 and $76,000 year 3 and $98,000 year 4. So for an average practice at 5 docs, that's a lot of money. It's a great opportunity. And these are cumulative. So if you choose to not participate in the program, you can get up to a $273,000 cut over 4 years. Or if you choose to participate, you can get up to a $273,000 increase. So a real great opportunity here either way. But you want to make sure you're going for the incentives and not getting the opportunity for the cut. So now diving into some of the measures. And again, I can't spend all the time because we only have about 5 minutes left to try to make this high impact with a lot of good content, but we're sharing all of this content with you. We want, and you can view it at your leisure and at your speed and pace, but we want to make sure that we showed you all the measures. This is not some black box. This is very transparent. It's very easy to understand, and also, you probably, certainly if you do PQRS, you do a lot of this today, a lot of this capturing and reporting of this information. And this is just all integrated into what MIPS is doing. So again, I'm going to keep rolling through here. We got 20 measures, and again, for cardiology, you only need to choose 6, but they gave you 20 to choose from based on your practice, specialty. Controlling blood pressure. Many cardiologists do that, and that's an outcome measure. That's certainly will be one of your 6 that you'd want to choose from, I would assume. But also, that brings up a good point. You bring in a practice or a partner like us to help you. That's something that we do we'll offer you, say, the 10 that we would recommend after analyzing your workflow and looking at your business. Say, hey, these 10 might be best. You pick which 6 you want, but here are the 10 that we might recommend. So that's something that a best practices partner would do for you. So again, just rolling through. Again, we'll be sharing all this content with you here. Now the outcomes measure, because you got to pick one, and there are 19 general quality outcomes measures included in the final rule. And you can go through these and look for any ones that are relevant to you. And again, just for the sake of time, I'm going to keep on going, but you can review the slide deck and review this presentation again, and look to learn more about these these measures. I do want to make sure I leave plenty of time for questions. Now, on the improvement activities, you have 93 to choose from, and you got to pick either 4 medium weight or 2 high weight. So, and again, we're going to roll through here all 93 right now. And the reason we want to show these, and it's not like we're trying to go fast, it's that I just want to make sure that you have everything that you need in one presentation if you're a cardiology practice. And we do this for lots of specialties, but for cardiology, this is all that you really need to know, or to at least begin to educate yourself really well, and then we can talk about the best practices on how to implement. So those are the 93 improvement activities, and here are 5 ACR measures, advancing care information required measures. And if you're doing meaningful use, if you've done meaningful use, again, very well positioned to succeed here. Okay, so what will it take to succeed financially? You know, you want to make sure that you're looking at the bottom and that you're not relinquishing any money that you've earned. Everybody's working way too hard. I promise you, I don't leave any money on the table. But practices leave at least 20 to 30% of additional revenue in the, kind of out there and just not collected. And we love to, we bring in usually 5 to 15% of that just through some best practices and a lot of other hard work and tenacity. So it's very important to look at it from that lens, and look for the efficiency, because you want to improve the financial and the clinical health of the practice. This is all going to become very important when you start to deploy strategies around quality reporting, value-based medicine, and certainly MIPS in the quality payment program. So pay close attention to the nuts and bolts, optimize your coding and your comprehensive coding. You want to make sure the claims are going out clean, denial management, going after the root cause, mitigation, and resubmission. Appeal 100% of your denials. Look at eligibility verification and best practices there, certainly around authorization management. Look at payer contracts and variance rates, and certainly have KPI monitoring set up on your revenue cycle as well as your clinical side and your quality reporting. If you do that on both sides, you will have at least 5 to 15% additional revenue and cash flow. Great opportunity there. So population, and what does it take to succeed clinically? You want to focus on population health and care coordination. MIPS walks you right through that. The quality payment program walks you right through that. And you will start to integrate data from clinical and financial sources. Again, make sure that you customize your EHR, you reduce the amount of clicks by implementing best practices, coding in the right areas, have your dashboard set up so you can capture the information, monitor it, and report it. You want to get paid for all your hard work. Implement best practices across the board where you can, and certainly where they're applicable. We recommend a monthly scorecard, if not a quarterly one. We discuss both of those options with our partners. It's just a great way to stay on top of your money, make sure you got the cash flow that you need, the revenue increases that you've wanted and you've been guaranteed, and then just make sure that you're coordinating care across the entire care continuum to improve and optimize outcomes. You'll be paid more as you do that, I promise. And then certainly patient engagement, patient education, and empowerment. We want to utilize patients. They're the most underutilized resource in a practice. It's not all about what the nurses do, the doctors do, the clinic staff or the medical practice staff. We want to make sure patients, they're inputting their drugs. You can always verify it, but they're sending you information for the medical record, or they're adding it before you, and then you verify it, of course. But they're a great resource. Make sure that they're engaged in a portal. You're educating them. You're giving them information for them to be more informed about their health care. You both will make more money and save money where they need to if you do that. And for everybody that knows me, I personally believe that all care providers that intentionally and deliberately engage with new payment and care delivery models and create the right partnerships will have more opportunity in the future than they have today. I live and breathe this every single day, and it's fun and it's exciting. So a couple of resources before we take some questions here. This QPP site website, the Quality Payment Program website by CMS, fantastic if you want to also go out there and see all the measures, but we actually show them to you on our webinar and in part of the slide deck, but you always go out and check them out on the QPP site. We have always a running list of webinars and best practices that we do and we share. iHealthInnovations.com and the webinar and the events link will show you that. And then CMS also has another great site called innovation.cms.gov that highlights all the value-based medicine and value-based payment programs available in your community. All the ones that are done by the federal government, but even some done by commercial payers. It's just very informative. So, Alex, I'd like to turn back over to you and see what kind of questions we have.
Thank you, Justin. We are just at the top of the hour, so out of respect for everyone's time, we'll only address a couple of questions. Our first question says, does an intermediate outcome measure count towards the required outcome measure, or would we still need to select one from the general outcome measures list?
Yeah, that's a great question. It does qualify and it would count because it is a medium weighted for cardiology. So yeah, you would be in good shape there.
Just to clarify, it's a high weighted.
I mean, it's a high weighted, yes, that's right. So it would count for cardiology. Thank you, yes. You're
correct, yeah. Next question, will my practice automatically receive a negative payment adjustment if we are not on the MIPS EHR edition?
No, and that's actually a great question because that's a misnomer out there. You do not have to be on the MIPS certified EHR. There's other reporting options. I certainly encourage you to push your vendors to get on the MIPS certified EHR. However, you could certainly the one quality measure, the one improvement activity, or the 5 advancing care information measures, you can do those separately. And actually, you would still have to do 5 measures, even though it's option 2 under ACI. But you can do all of that without having a MIPS certified EHR. So, but also you can even do more without a MIPS certified EHR. But I recommend having one if you have access to one.
Thank you. And our final question says, MACRA, MIPS, QPP, this is all so overwhelming. Where would you suggest that we start?
Well, that's a great question. I get that frequently. So you've already started. You've already taken the time to listen to this webinar, to hear my voice. So you're probably going to be very well positioned. If you digest this information, you have any additional questions or anything like that, feel free to reach out to me personally, email, social media, my company, or even the QPP website is a great place to continue to learn. And then certainly we offer a lot of best practices and check in back with us. Love to help in any way.
All right. Well, thank you, Justin. And a special thank you to everyone for taking the time to attend today's webinar. It's all about revenue, MIPS, and cardiology best practices. Once you leave today's webinar, you'll receive a survey on the presentation, and we would appreciate if you'd complete that and provide your feedback. As a reminder, today's slides will be shared in a follow-up email within 24 to 48 hours, and we will also include a link to view a recording of the webinar in case you want to review again or share with any peers. On behalf of iHealth Innovations and our presenters, thank you for joining us today and have a great rest of your day.
Thanks all.